welcome for everyone. I am very happy that you are here, and I really feel appreciated that I can talk to you about self-compassion and self-harm and mindfulness-based interventions. It is especially important for me that after we listened to Daniela Lucangeli's lecture about the technical devices and the harmful effects on children and the central nervous system of children and adolescents, it's really a kind of era where we live, where they can be used well, and of course they can be used unwell. And since not only children and teenagers, but all of us, we live in a kind of information flood, and lots of information are around us like tsunami. And our central nervous system is not designed to deal with so huge amount of information. So our culture, civilization, and science must give kind of answer for that information flood, I would say, or information tsunami. And even if I am going to talk about mainly about patients with emotional dysregulation, but I think all of us in the need of somehow being able to handle and regulate the information which is, as I just told, flooding our minds. So the structure of my presentation would be that first I would like to start from understanding depression and suicidality, then understanding borderline personality disorder and self-harm, and I would like to show how important it is to think about this phenomenon, and then of course the treatment possibilities from self-harm to self-calm. So let's start with suicide statistics. We know that it's a very serious problem, and the global suicide rate is approximately 16 per 100,000. But which is more important fact that the fatal suicide rate has increased by 60% since the end of the Second World War. And it cannot be understood just because of genetics and biological factors. Of course, the changes in the society and environment play a very, very important role in that. And if just for a glance, we take a look on this world map of suicide rates, at first glance we can see that, you know, the darker the color, the higher the suicide rate is, and the lighter the color, the lower the suicide rate is. At first glance we can see that this is not the money, which we know, of course, that this is not the money and the wealth which makes us happy and lives and helps our lives, but if we take a look on this map, we can see that the Arabic countries and the South American countries and the Latin cultures and the Arab cultures, which live in big communities, religion is important. Of course, there is lots of sunshine, but more important, the social support and big communities and the family ties, which are very similar in these countries. So it seems that it's really important protective factor in suicide. So if we take a look on the risk factors for suicide, there are primary, secondary, and tertiary risk factors. Primary risk factors, psychiatric illness, not only depression, but schizophrenia and drug and substance abuse. Of course, previous suicide attempt, family history of suicide, and comorbid anxiety. There are secondary risk factors such as early childhood losses, isolation, unemployment, serious negative life events. And the risk factor also, if someone is born to be man in the middle age or over 75, and even adolescent. And there are vulnerable periods like, for example, springtime, or being a doctor, or being a helping professional. There are risk factors which are modifiable and which are non-modifiable. So the non-modifiable risk factors are, as I just mentioned, gender. So men are more vulnerable than women. The age, I just told this, nationality. For example, if someone is born to be Japanese or Hungarian, are more vulnerable for suicide than, let's say, for Polish or French, because of the culture, which is a kind of protective risk factor. Religion, non-modifiable, chronic illness, as I mentioned, previous attempt, and if there were some kind of suicide in the family, as somebody, depressed person, for example, reports that he had a previous attempt or suicide in the family, we have to take very seriously his suicidal or her suicidal intention. But as counselors, as psychologists, as psychotherapists, we focus on the modifiable risk factors, of course, because these are the factors which can be changed. For example, socioeconomic status. For example, when someone is unemployed, can be helped to find some kind of employment or job. Mental health, of course, modifiable. If someone is depressed, there are many good treatments for depression or other mental problems. And psychological factors such as hopelessness or low level of problem-solving skills, these are modifiable risk factors. So first, just very briefly, I would like to go through depression before I turn toward this emotional dysregulation. So we know from studies that the majority of suicide attempters suffer from major depression, and the prevalence of depression in the general population in Europe is approximately 10%, and which is also very important that untreated depression is very dangerous, because in conditions of untreated depression, people attempt and commit suicide. And 50% of the attempted suicide suffers from depression. And this is the hopelessness theory, which gives a good answer for us why people turn toward this very, very bad solution, I would say. That this is not only depression, but other diagnostic categories like schizophrenia or substance abuse also, of course, attempt and commit suicide. So this is not depression itself, but hopelessness, which is a predictor of suicide intent. And it's a better predictor than the diagnosis, depression diagnosis itself. Why hopelessness is so risky? Because this is the loss of the anticipation of the future, lack of perspective, and it leads to hopelessness and helplessness, because the person somehow cannot see how to come out of the situation which he or she is in. And it was Aaron Beck, the founder of cognitive behavior therapy, which brought a huge paradigm change in our thinking about human personality and in psychotherapy, that he dealing with depressed people and suicidal depressed people, he discovered that this is the hopelessness, which is a main predictor of suicidality. So therefore, he created a scale called Beck Hopelessness Scale. And it's a 20-item scale. However, there are 3 items. We made a research on them, and these are only 3 items which good enough, strong enough to predict someone's suicidality. My future seems dark to me. Things just won't work out the way I want them to. And there is no use in really trying to get something I want, because I probably won't get it. I would like to tell you that we are very happy and glad and proud that the Hungarian Emergency Hotline Society started to use it, and when there are the person the receivers every room or office there is this back hopelessness scale, the short version. So if the caller tells this, that my future seems dark to me, or there is no usually trying to get something that that we can know that yes, he or she is really suicidal. And it was Marx Williams who somehow summarized all the research about suicidality. And now what we know that before someone gets to suicidal, in the background there are usually vague autobiographical memories, for example, in the family or in the social environment, how to solve social problems. The person doesn't know how to solve the problem, so gets depressed, and the kind of negative thinking style rises that I cannot solve my problem. And when someone thinks this way about these problems, or there is a negative problem orientation that it's impossible to solve this problem, there is no way out of the situation, it shows that he or she has low problem-solving skills, and it leads, of course, to a loss of anticipation of the future, hopelessness, and this is actually the last step before the suicide attempt. So this model is supported with many, many studies, and suicide prevention and in dealing with chronic depressed patients based on this helplessness model and entrapment model of suicidality. On the other hand, now, especially after the COVID, but not only the COVID, now we face another increasing problem, which is borderline personality disorder. And just to show to you what are the main characteristics of borderline personality disorder. There is a fear of abandonment. These patients have very, very unstable relationships, very unstable identity. They don't know who they are. There are extreme emotional swings between positive and negative emotions, chronic feelings of emptiness, explosive anger, impulsive behaviors like drug abuse or bulimia or eating disorder or dangerous driving, and which is our main topic today, self-destructive behavior, self-harm. Why am I raising this topic? Because in healthcare, I work in healthcare, we have a big outpatient ambulance at the Department of Clinical Psychology. And what we found in the last 10 years that more and more young people between 25 and 35 come to see us with this kind of problems. So there is an increasing demand. In general practice, approximately 6%, but what is more important that psychiatric outpatient care, almost 10% of patients borderline, and inpatient care, approximately 20%. And so it's a huge number. And of course, there are, it's a very serious condition, borderline personality disorder. Many times in the background, there are abuses, sexual, physical abuse in childhood. And there are first-line evidence-based good effective therapies like dialectical behavior therapy, schema therapy, mentalization-based therapy. However, these are approximately 1 year long, and there is a difficult access to these psychotherapies, not only in Hungary or in Central Europe, even the United States, which spends the most money on healthcare, but there is very difficult to access good and long psychotherapy. And there is a shortage of well-educated therapists. Just in Australia, it's a study that just in Australia, there is the finances show that 34 million Australian dollar was the cost in 2009 on borderline personality disorder treatment. So it's very, very expensive. As I mentioned, the last but most dangerous characteristic of borderline personality disorder is the so-called self-harm, self-destructive behavior, and non-suicidal self-injury. I suppose there are several calls from them on the emergency hotline. I suppose you have also experiences calls from these young people. And this repeated non-suicidal self-injury has low lethality, but still very, very, very dangerous. In their case, the motivation is different from depression because a depressed person wants to die. That's why he or she commits suicide. But not the borderline patient. Borderline people don't want to die, but this very intense emotional state and impulsivity, this is what they want to decrease. And this is only some very strong, intense body feeling which can decrease this psychological pain. That's why they hurt themselves. And this is what we call non-suicidal self-injury. But it's very frightening, this number, that approximately 10% of borderline people, borderline patients, complete suicide. It's a very, very high number. And you can see that 57-75% attempt self-harm or commit self-harm at least once in their lifetime. You can see here a part of our study, what I would like to share with you, but just now one slide, that these methods, non-suicidal self-injury methods, hitting, cutting, biting themselves, and most of them use not only just one, but 2, 3, or 4 methods of non-suicidal self-injury. And this is the frequency. You can see that lots of them committed daily or on a weekly basis, and of course on a monthly basis also. So what happens in them? What is the background of this non-suicidal self-harm? This is what we really would like to understand. There are several models from them. This is the emotional cascade model, which describes what's going on inside in these people. So there is a stressful life event, which triggers some, let's say, a conflict, and it triggers a negative self-image that I am bad or I made a mistake, and they start to ruminate that, oh, I should have done something different. And it increases their negative emotional state, then they further ruminate, and then they are caught in a vicious circle, which I will show you in a moment. And they find themselves in an extreme negative emotional state, a kind of cascade, which they are not able to come out. But somehow it is so intense that they feel that they have to do something. And they do, in fact, something. They try to regulate this and decrease this intense psychological pain on a dysfunctional way by drug, alcohol, and things like this. And only there's cutting or alcohol or binge eating or hitting, which body sensation good enough or strong enough to decrease this emotional cascade. So the clinical... The microphone. May I have it? Yes. Conclusion that we need to help these people to come into the present, to control their attention, instead of ruminating, to be aware of what's going on in the present in their life. And this is what I just tried to explain to you, that here is... there is a perceived or real social conflict or isolation. It can be a normal conflict, a quarrel with a partner. Then the negative shows that I am isolated, I am alienated from others, I deserve suffering. Of course, as a consequence of the negative feelings, negative thoughts, they have lots of negative feelings, hopelessness, shame, anger. They start to ruminate, and it increases so much that they feel that they have to do something. And this is the self-harm what they do, and the tension decreases. So that's why this very dysfunctional, maladaptive way of coping, the non-suicidal self-injury, reinforced by the decrease of the anxiety. I don't know, can you follow it? So this is the very, very dysfunctional way of dealing with the tension. I try to step. May I have another MBCT? Okay, thank you. So here is the self-harm. Behind that is impulsivity, behind the emotional dysregulation, behind it there is a deficit in mindfulness skills, in other words, to be in the reality. Behind is low self-esteem. And this is what we started to deal with. Okay. Thank you. So the text now just explains what I mentioned to you, but what research shows that improving mindfulness skills, what does it mean? To step back into the reality can reduce rumination, kind of distance from negative thoughts. Thank you. And I would like to show to you our study. 120 person took part in our study. And here you can see that borderline patients, depression, impulsivity, and maladaptive coping much higher than the healthy standard or normal control patients or people. So depression, impulsivity, and non-adaptive behavior much higher, while compassion and mindfulness skills are while self-compassion and adaptive cognitive emotion regulation and mindfulness much lower than the healthy standard and normal control persons. And that's why we started to think about that maybe the mindfulness approach, which is very popular in psychotherapy and developed a lot, can be adapted to borderline problems as well. Yeah. So maybe if we change, I would be very happy. So here you can see that self-compassion and acceptance decreases the frequency of NSSI, impulsivity decrease. Let's give it a try. Okay. So that's why we started to think about it, that maybe mindfulness approach could be adapted to this very special population. And in order to understand the background of that very short background, I would like to show to you that Marsha Linehan published the most important theory and treatment for borderline personality disorder. This is called dialectical behavior therapy. And she described that emotional vulnerability, increased sensitivity to emotional stimuli, intense reaction to this emotional status, and since intense emotions subside just very, very slowly, it's a kind of biological disposition, since these are the most important characteristics of borderline personality disorder, therefore she addressed 4 treatment modules of dialectical behavior therapy. So first of all, she suggested, and this dialectical behavior therapy, DBT, includes teaching mindfulness skills, then after mindfulness skills, we teach interpersonal skills, then frustration tolerance skills, nem tudom, mi történik. Interpersonal effectiveness skills, emotion regulation skills, and distress tolerance skills. So these are the 4 main modules of DBT. And as I just mentioned, it's a very complex 1-year psychotherapy, which is not accessible just for a few patients. So what can we do when there are so huge patient load and young people, and not only young people, come in with non-suicidal self-injury and self-harm behavior? We saw that a kind of low-intensity, kind of emergency solution, of course not emergency because mindfulness is not emergency, but a short intervention, mindfulness intervention, can help the borderline people at least survive themselves and to be alive while they reach proper psychotherapy, the long psychotherapies. No. Yeah. And here I just wanted to tell to you that mindfulness not only popular but really effective, and I think this is not just a kind of fashion, because we have to be suspicious when something is so fashionable, but mindfulness, a kind of attitude toward life, which it seems for us that gives answers to the questions of the people of the 21st century during these emotional disturbances, crises, and information tsunami. So there was a book which was published, Mindful Ways Through Depression, by an Oxford University team. You can see them. They are very nice people, and this book I can suggest to you. It is very useful for professionals, but also for patients and like people. I give it to my patients also. There's a Hungarian version, and they come back that, oh, it's about me. So it's really very useful. And what are the results? The results are very, very promising now in depression, recurrent depression, up to now, until mindfulness was somehow, and mindfulness-based cognitive therapy was discovered for chronic depression. So up to this point, only medication and tablets were the treatment actually for chronic depression. But here it's very, very promising and hopeful to see that the line, the back line, there is no laser pointer in this, so, but anyway, so you can see that mindfulness-based cognitive therapy and EDM means antidepressant medication. So antidepressant medication and mindfulness-based cognitive therapy has the same effect even at the 2 years follow-up. So it seems that it's really helpful, even depressed suicidal patients, when they are somehow ruminate about their worthlessness, negative self-esteem, and it doesn't make sense to live, and life doesn't make sense for me. They have these very, very negative thoughts in their mind, and in this state they step back and start to realize the present situation, because mindfulness is kind of awareness of the present situation. So other studies also show that not only in depression, but there are just a few studies that truly borderline patients has a mindfulness deficit, and the studies show that there is a significant negative correlation between mindfulness skills and emotional dysregulation and borderline traits, meaning that borderline patients absolutely ruminating in their mind without being aware of the reality. Another study showed that experience with 10 weeks of MBCT, which focused on emotion regulation, decreased the borderline symptoms. They were able to decenter from the situation and were being able to be non-judgmental. So these 10 weeks MBCT increased their ability to regulate emotions, increased ability to be present in the present moment, increased non-reactivity and non-judgment, and their impulsivity was reduced. So it seems that it's really a promising approach to do. And let's see what are our results. No. Even if mindfulness is very popular, if we have to define it, we could define it that it's a mental state achieved by focusing on one person's awareness on the present moment, by calmly acknowledging and accepting one's feelings, thoughts, and body sensations on a non-judgmental and non-reactive way. What does that mean? It means that everyone has experience with conflicts. Everyone has conflicts in everyday life, and we react to that. We have intense emotions, anger, or worry, or fear, or something like this. But in a mindful state, we teach borderline patients and even ourselves to be present that, okay, it's a situation that the other person has a different view than me. I feel anger, for example, or I feel worry, I feel fear, and I have thoughts that, this is the end of the world. But this is just a thought that this is the end of the world. These are my feelings that I am angry or I feel palpitations. This is mindfulness, to be aware of my body sensations, emotions, and thoughts. And this way, I am able to be in the present instead of catastrophizing that this is the end of the world, I cannot live with this person anymore, and I have to do something. Does that make sense to you, this difference? So this is what we do with mindful patients. And if we want to summarize what mindful attitude is, besides awareness of the present moment, for example, as probably you are not aware of it, but if we are mindful, we can be aware of it, how we sit, for example, now on the seats, and our body is on the seat, and how our leg and toe feels now in the shoes, for example, to be aware of this body sensations. This is to be aware of the present moment. Then the acceptance of the reality that, okay, it is a conflict, it can happen, this is the reality. Even if I don't like it, it is here, so this is the reality. Letting go of expectations. For example, I shouldn't have conflicts, never ever. So letting go of the expectations that, okay, it can happen. With patience and open mind, on a non-judgmental way, that it is allowed, it's okay to happen conflicts, for example, not reacting immediately, and to keep distance from the thoughts. So this is mindfulness-based cognitive therapy in depression, in hypochondriasis, and in borderline personality disorder, to keep a distance from our thoughts, that our thoughts, even if they are our thoughts in our mind, but they are just mental events, and we have approximately 60,000 thoughts per day. This is the basis of our creativity, and we cannot control our thoughts, but we can keep distance from them, and this is definitely not the reality. So even if a borderline patient has a conflict and thinks that this is the end of the world, he or she can learn to come back to the present moment and just to accept that it can happen. It's not the end of the world. I think it's a very good figure. We use it very, very, very useful, that your body is present, and where is your mind? And the other part of mindfulness is, I go briefly, that self-compassion. Part of mindfulness trainings, self-compassion is part of mindfulness training. And just to compare that self-compassion means that self-kindness, instead of judging oneself, to accept that conflicts, problems occur just because we are humans, instead of isolation or that it's shameful and I should hide myself. And mindfulness, being present instead of over-identification. This is Christian Neff, probably you know her. She wrote several books about self-compassion. And so what is the main goal for borderline patients? You can't stop the waves, but you can learn to surf. So this is what we try to teach them. Back, would you? Okay. And at the Semmelweis University, during the COVID era, we were asked to help the other clinics like gastroenterology and all the other clinics, pulmonology especially, to help the professionals, I mean nurses, doctors. And this was the Lancet which published a very short 2-minute exercise, so we can do it together now. Even if in moments of crisis, just close your eyes, give yourself some time and stop for a moment. As you breathe in, focus your attention on your breathing. As you exhale, relax every muscle of your body. Feel how your feet touch the ground. Feel the safe ground under your feet. Let yourself go into this experience and relax here for a while. Okay, thank you. You can open your eyes. This was how people lived, professionals, during the COVID. So they had 1 or 2 minutes, but still somehow it was helpful for them. And now, just very briefly, I would like to show to you the results of our study. First of all, what we changed in this mindfulness-based MBCT, mindfulness-based cognitive therapy for depression. What did we change? We changed just the green parts. We included more loving kindness exercise, pleasant experiences, and the loving kindness was repeated 3 times during this 8-week mindfulness training. And we consulted Mark Williams from Oxford, and it gave us a very, very safe background. What is loving kindness meditation? This helps us cultivate compassion, kindness, acceptance, and love for ourselves and all others. By directing caring feelings towards oneself and others, the aim is to develop a state of unconditional kindness as well as appreciation of our oneness with others, recognizing that all beings, including ourselves, have the desire for happiness and peace. And here are the results with this really serious psychiatric diagnostic group. Mindfulness skills increased after the 9-week, 0 week, which was the first interview, plus the 8-week-long MBCT training. So we can see that after 9 weeks, mindfulness skills increased a lot. Compared to waiting list and compared the dropouts. Then self-compassion increased also significantly compared to the waiting list and the dropout. impulsivity decreased very significantly, and it was one of the main goals, in self-harm. It's an extreme high vulnerability factor, so it decreased a lot. And even if depression was not an aim, was not in a focus, it decreased after the 9 week. And emotion regulation also. Here you can see this is the adaptive strategies, for example, seeking help or taking perspectives increased, while maladaptive strategies, by taking drugs or driving very fast, decreased significantly with the high significance. So if you want to summarize somehow which patients, I would say, cool down. So maladaptive emotion regulation strategies decreased, rumination decreased, outward anger decreased, non-judgmental attitude. In other words, they were able to accept themselves that it's okay to have problems, for example. It's okay to be angry. So non-judgment attitude increased, self-compassion and self-esteem increased, and luckily non-suicidal self-injury decreased. So we think that this not very long 9-week mindfulness training can help borderline patients, and while they go to long psychotherapy. Unfortunately, I cannot show the last slide, but this is the last slide. So thank you very much. Thank you very much for your attention.